Welcome back. It's now time for the final panel of our day. We still have a lot of great material that's going to cover the intersection of disability with other identities, disparities in health risks and access to services, future directions for policy and research, and more. Our final moderator is Dr. Omar Beg. Omar is a clinical resident in psychiatry at Massachusetts General Hospital. Dr. Beg will lead us through the last session, introduce the speakers, and then I'll come back to close us out. Dr. Beg, over to you.
Sounds good. Thanks, Alan. I'm very happy to be here today hosting this panel that really brings together authors who will address a diverse range of topics in disability and health. There's a lot of ground to cover, so we will get right to it. I'll very quickly introduce the presenters, and then they'll present sequentially, and then hopefully we'll have a good amount of time at the end for questions. Our first presenter will be Dr. Tyler James. He's a research fellow in the Department of Family Medicine at the Center for Disability, Health and Wellness and the Michigan Mixed Methods Program at the University of Michigan. After that, we'll hear from Ari Naiman, who is a PhD candidate in Harvard's Health Policy Program and a senior research associate with Harvard Law School's Project on Disability. He is doing double duty for us today, as he is the first author of two very important papers that he'll discuss. Next, we'll hear from Dr. Willie Horner Johnson, who is an associate professor at the Oregon Health Sciences University and Portland State University School of Public Health, as well as an associate professor at the Institute on Development and Disability at OHSU School of Medicine. Then we'll hear from Madeline Smith Johnson. They are a doctoral student and graduate research assistant in the Department of Sociology at Rice University. And then afterwards, we'll hear from Lauren Elizabeth Bixby, who is a PhD student at the University of Pennsylvania. And finally, we'll hear from Dr. Alina Engelman, who is an associate professor in the Department of Public Health at California State University, East Bay. And so without further ado, I'll turn it over to Dr. Tyler James.
Thank you so much, and thank you to Health Affairs and to everybody who's in attendance this afternoon. My name is Tyler James, and I'm the lead author on the study Communication Access and Mental Health and Substance Use Treatment Facilities for Deaf American Sign Language Users. I'd also like to recognize my co-authors, the majority of whom are deaf and who use sign language to communicate, and four who specialize in mental health or substance use treatment for people who are deaf. This includes Michael Argany, Jamie Wilson, Michael McKee, Donna Gardino, Megan Sullivan, Aaron Grice-Schwartzman, and Melissa Anderson. Next slide, please. Deaf and hard of hearing patients who use American Sign Language to communicate are at extremely high risk of mental health and substance use related conditions. The development of these conditions, of which are associated with poor language and social development outcomes related to early childhood language exposure, lower socioeconomic position, and discrimination. Several studies have indicated that deaf sign language users are at least 2 times more likely to experience interpersonal violence, depression, anxiety, and substance use. When these deaf patients access mental health treatment facilities, communication access is necessary to provide a history of their symptoms and to enable them to work with their providers to determine a suitable treatment approach. As mentioned in this afternoon throughout this briefing, communication access in healthcare facilities is protected by disability civil rights laws, including the Americans with Disabilities Act of 1990 and as revised, and the Section 1557 of the Affordable Care Act, or the ACA. The differences between these two regulations, however, are extremely important. Under the Americans with Disabilities Act, healthcare organizations such as hospitals, dental offices, and mental health facilities were considered under Title III of the ADA as places of public accommodation. Under Section 1557, they are effectively held to a stronger standard under ADA Title II, or ACA, similar to ADA Title II, I should say. Despite these protections, there have been several lawsuits and published research studies indicating that healthcare environments are not providing effective communication access to deaf patients. The widespread lack of accessible healthcare communication access further traumatizes deaf patients and diminishes patient experience and treatment engagement. This study used publicly available data from the U.S. Substance Abuse and Mental Health Services Administration, which administered 2 surveys in 2019 focused on mental health and substance use treatment facilities. And we use this to assess facility noncompliance to Section 1557. These surveys represent the entirety of treatment facilities within the United States, with only a few exceptions, such as the exclusion of Department of Defense facilities and jails or prisons. Facilities were then categorized as non-compliant or compliant, and then the proportion of these facilities were mapped by state. And we did this in 2019 using pre-COVID data to reduce the limitation and confounds of COVID and the COVID pandemic. Next slide, please. We measured non-compliance based on a conservative definition using the definition of facilities mandated by Section 1557 called covered entities. Mental health or substance use facilities that received public funds, such as from the Substance Abuse and Mental Health Services Administration, Medicare, Medicaid, or Indian Health Service, that reported not providing services in sign language to deaf patients were categorized as non-compliant. The question used in these surveys were the same and was, does this facility provide mental health or substance use treatment services in sign language at this location for deaf and hard of hearing patients? For example, sign language, signed English, or cued speech. Now, although these types of accommodations for communication access are different, ultimately it indicates an access need for an accommodation that is different than spoken English. And so respondents were directed to mark yes if these services were available through facility or staff or an on-call interpreter service. Next slide, please. This is a map of showing the distribution of non-compliance per state in the United States in 2019. 96% of mental health facilities received public funds, and among these facilities, 41% were categorized as non-compliant. 17 states had more than 50% of facilities in non-compliance, with South Carolina having the lowest prevalence at 16%, and Wisconsin having the highest prevalence of non-compliance. Next slide, please. This is a map showing the substance use treatment facility distribution across the US. 78% of substance use facilities received public funds, and among those facilities, 59% were categorized as non-compliant. 35 states had 50% or more facilities in non-compliance, with Missouri having the lowest prevalence of non-compliance and Idaho the highest. Next slide, please. In general, more substance use treatment facilities than mental health treatment facilities were non-compliant with Section 1557. In fact, all but 3 states had a higher percent of substance use facilities that were non-compliant than mental health facilities. And this is just a map showing the 2 side-by-sides for comparison. Next slide, please. This lack of communication access increases the likelihood of healthcare-related trauma among deaf patients, further exacerbating mental health concerns and diminishing future treatment engagement. In addition, it is a violation of their civil rights protected by federal law and a breach of medical providers' codes of ethics. Lastly, it complicates deaf patients' healthcare navigation. If a deaf patient needs to receive mental health or substance use treatment services, but a majority of facilities in their state are non-compliant with federal law, they're not able to receive treatment. To remedy these issues, a multi-pronged policy approach is needed, including state and federal governments being proactive with monitoring compliance among these facilities and making compliance a requirement for accreditation and Medicare payments. We also need to increase access to deaf ASL fluent mental health providers who can treat deaf patients directly in their native language. To support this, we recommend the expansion of cross-state reciprocity for licensure and telehealth reimbursement agreements, in addition to developing pipeline training programs to increase the number of deaf ASL fluent providers. Next slide, please. Thank you. And now I'm going to pass the reins over to Ari Nema.
Well, thank you so much. I want to begin by thanking my co-authors, Michael Ashley Stein and David Grabowski, without whom this work could not have been done. And just to kick things off, really the most important trend in long-term services and supports policy, really I think one of the most important in disability policy in general, has been the shift away from institutions and towards community services. And while there are many different kinds of institutional settings, the most common form is the nursing home. And while we typically perceive nursing homes as a place for older adults, in fact, about 15% of nursing home residents are under the age of 65. That's a little more than 200,000 people in 2019. This isn't a small population, but it's actually one that often gets lost in the shuffle given that there are so many fewer people in this group than older adult nursing home residents, and because state and federal reporting on this population generally lumps in younger people with physical disabilities and older adults for purposes of reporting LTSS expenditures, and often at the state level for administering provider networks and benefits. So we really set out, next slide, to study this population as a distinct group. And to do that, we relied on the minimum data set, which provides granular clinical and demographic data on every nursing home resident in the country. It's a wonderful data source. We looked at the years 2013 to 2019, in part because there was a great deal of policy change specifically designed to bring people with disabilities out of institutions and into the community during that time period, a lot connected to the ACA, the shift towards managed LTSS, Olmstead litigation, a lot more. And I want to begin by highlighting some, I think, very concerning national trends. Next slide. So for younger people with disabilities, for persons under the age of 65, nursing home use over the course of our studying period has really only declined very slightly. We report both crude and age-adjusted rates in order to account for population aging. And even after we account for that, we've really only seen about a 6.5% reduction in nursing home utilization and number of nursing home residents in this age group per 100,000 state population over the course of our study period. Now, if we contrast that, next slide, to older adults, we have seen dramatic reductions in the number of older adults using the same population norm measure in nursing homes, approximately 20% reduction from 2013 to 2019 in the prevalence of older adults in nursing homes. So that really should worry us, in part because it suggests that the shift away from nursing home utilization, which certainly a very high priority for people with disabilities, has largely been missing younger people with disabilities. Next slide. We then split states into quartiles to look to see if higher utilizing states were converging with lower utilizing states over time. We found that they were not, which is again very worrying given that higher utilizing states have 3 times the rate of nursing home utilization for younger people with disabilities than their lower utilizing counterparts. And so when we looked at this comparing older and younger people with disabilities, we found that despite the fact that in all states but one, during our study period, there was at least a 5% decline in nursing home use by older people with disabilities. That was only the case for 23 states for younger people with disabilities. 19 states had largely stagnated, and 9 states had actually had increases in younger people with disabilities nursing home use that was greater than 5%. Next slide. I want to highlight some of the demographic and clinical differences in this population. First, and I think this, again, should concern us, we see that people of color are heavily overrepresented among younger nursing home residents. And really what this should suggest to us is that social determinants of health, housing, racial disparities, other similar issues are playing a major role in driving younger disabled people into nursing homes. Next slide. We also see that with the exception of children, rates of serious mental illness are much higher among younger nursing home residents than they are among older nursing home residents. Next slide. Also want to highlight the younger nursing home residents, again, with the exception of children, are much more likely to go into for-profit facilities and much more likely to go into lower quality of facilities. Should also be a source of concern. Next slide. Next, I just want to very briefly highlight, and you can just put the bullet points up there, some of the policy solutions that we've highlighted. First, as others have discussed, Medicaid has an institutional bias, so there's a need to expand home and community-based services. Second, if you put the, thank you. Congress established in 1987 a program called PASSAR, specifically to divert persons with mental illness from nursing home placement. And unfortunately, it appears that it is not being effective. We believe part of the reason for that is PASSAR has an exemption for screening and diverting individuals who are coming into a nursing home from certain kinds of post-acute placements. So we may want to reconsider that. Next bullet. We also argue that future home and community-based service incentive programs may wish to set sub-goals specific to younger people with disabilities to acknowledge the heterogeneity of this population. So I just want to close, if we could jump to the last slide. Thank you. For reasons of time, one more. By emphasizing that this is a population that really deserves unique attention. There are almost 200,000 of them. There are often ignored relative to older adults, but they have unique needs. And the future of LTSS policymaking has to consider this type of heterogeneity. Thank you very much. Without further ado, let me hand things over to my colleague, Dr. Horner-Johnson. Please take it away.
Thank you. And while my slides are coming up, I'll go ahead and thank my co-authors, Mikola Desanayaki, Nicole Marshall, and Jonathan Snowden. I am fighting a cold today, but I hope my voice will hold out while I talk about perinatal health risks and outcomes. And as soon as the slides are ready. Great, next slide, please. The reproductive rights and parenting rights of people with disabilities have long been neglected at best and often actively curtailed, which helps explain why, until quite recently, there was very little attention to perinatal health of people with disabilities. But in the past decade, a rapidly growing body of research has highlighted stark disparities in perinatal health risks and outcomes for birthing parents with disabilities and their infants. Most of these studies have inferred disability from diagnosis codes in hospital discharge records and medical claims data. While that's a useful approach when we don't have any other source of information about disability, diagnosis codes are not designed to provide information about how people function or interact with their environments. So the link between diagnoses and functional limitation or disability is not always clear. And diagnoses recorded for a particular visit will primarily be focused on the purpose of that visit, not on other pre-existing conditions. So it's likely that births to people with disabilities are undercounted in studies relying on diagnosis codes. Survey data offer an alternate approach. The Affordable Care Act mandated collection of data on health disparities, including those affecting people with disabilities. In response, the U.S. Department of Health and Human Services adopted a set of 6 disability questions for use in population-based health surveys. One of the first surveys to add these questions was the National Survey of Family Growth, or NSFG, which also collects data on pregnancy experiences and outcomes. Next slide, please. For this study, we analyzed NSFG data from 2011 through 2019. We identified singleton pregnancies that lasted at least 20 weeks and ended in a live birth. And we used the 6 disability questions to determine the disability status of the respondent associated with each pregnancy. We then compared pregnancies among respondents with and without disabilities on smoking during pregnancy, delayed entry into prenatal care, meaning that care was not received until after the end of the first trimester, preterm birth prior to 37 weeks of gestation, and low birth weight, defined as less than 2.5 kilograms at birth. Next slide, please. A central finding of this study was that 1 in 5, or 21% of the births we analyzed, were to respondents with disabilities. That is a much larger proportion than has been found in previous studies in the US that have used diagnosis codes to identify births to people with disabilities. Proportions in those studies have ranged from less than 1% to about 6.5%. As I said earlier, we knew those were probably underestimates. And this new study clarifies that when we're talking about perinatal experiences of people with disabilities, it's not just a small fraction of births. We're talking about 1 out of every 5 births in the United States. We also found that pregnancies among NSFG respondents with disabilities were characterized by significantly greater risk than pregnancies among respondents without disabilities. In other words, the disparities shown in previous studies don't just apply to that small sliver of the disability population that can be identified with diagnosis codes. They apply far more broadly. In this study, where we had a more comprehensive means of identifying disability, we found very similar patterns of disparities. Next slide, please. The biggest difference we found was in smoking during pregnancy, which occurred in 19% of pregnancies among respondents with disabilities, compared with 8.9% of pregnancies among respondents without disabilities. We also found that delayed prenatal care, preterm birth, and low birth weight were significantly more likely when the birthing parent had a disability. Next slide. In our adjusted analyses, when we took sociodemographic differences between people with and without disabilities into account, we found that pregnancies among respondents with disabilities still had 46% higher risk of smoking during pregnancy, 24% higher risk of preterm birth, and 29% higher risk of low birth weight compared to pregnancies among respondents without disabilities. Next slide, please. Excuse me. Based on our findings, it appears that perinatal disparities associated with disability are much more widespread than has been indicated by prior research in the United States, with 1/5 of US births affected by these disparities. Next bullet. These findings have important implications for action, and I'll focus on 2 of the main ones. First, clinicians need to ask people with disabilities about their reproductive plans. Some of the disparities we observed could be reduced if people with disabilities had opportunities to proactively discuss reproductive goals, prepare for healthy pregnancies, and receive appropriate care throughout the perinatal period. Next bullet. Second, we always need to include disability questions when collecting demographic data. And this applies across the board, not just to perinatal health. In order to identify disparities and monitor progress toward eliminating them, as required by the Affordable Care Act, we have to consistently ask about disability, just like we ask about race and ethnicity, and gender and sexual orientation. That's important in surveys, and it's important in clinical settings, because when we rely only on diagnosis codes to identify disabilities, we're missing a lot of people. So collecting self-reported disability data in healthcare settings is crucial for better assessing disparities in care and outcomes, and more fully addressing the health equity provisions of the Affordable Care Act. Next slide, please. The fact that we're devoting today to talking about disability and health, and that perinatal health is part of the conversation, is such an important step forward. But of course, we can't stop here. I hope today will lead to real changes in how data are collected, how healthcare is delivered, and in health outcomes. Thank you.
Perfect, thank you. So I'm here to talk about the rates of disability by gender identity. So we're diving into a specific subpopulation here. Next slide. And first, I want to give a little bit of background about what we know about gender disparities in disability. So a long history of literature has documented that women tend to report more disability prevalence compared to men. And this scholarship really tends to focus on cisgender adults. So it ignores the experiences of transgender adults, except for the fact that one study out of Massachusetts found 23% of transgender adults reported an activity limitation because of disability. And this was significantly higher than the non-transgender comparison group. So I wanted to know whether these results were generalizable to other states. And to do that, I drew on data from the Behavioral Risk Factor Surveillance System from 43 US states. Next slide, please. And my study found that in a sample of over 1 million respondents, so pooling the cross-sectional data from the BRFIS from 2014 to 2020, which includes a subcategory of nearly 6,000 transgender people, the BRFIS started asking about gender identity in 2014 in a way that included a transgender response. And we see that 30% of transgender adults reported at least one functional limitation. And here I'm aggregating 4 measures. So whether a respondent reports having serious difficulty dressing or bathing, walking or climbing stairs, running errands alone, and concentrating, remembering, and making decisions. Next slide. And we also see, just looking at the sample, that the sample of transgender adults are more likely to be a racial minority, have low income, have less than a college education, and are more likely to be a current smoker. And we know that all of these things can tend to influence someone's risk or propensity to have a disability. And so I wanted to know that whether after controlling for these and sort of looking at the distribution of disability over different age groups, whether we see these higher rates of disability among trans adults. Next slide, please. And in fact, we do see higher rates of disability among transgender adults at every age group. So this graph shows the adjusted predicted probability of reporting at least one disability. And you can see the blue line on top represents transgender adults relative to cisgender women and cisgender men. And these estimates are controlling for socioeconomic status, health behaviors, and healthcare access. And so you can see that while you have this persistent disparity between cisgender men and women, and this gap is still pronounced as the cohorts get older, the size of the gap for transgender adults is truly staggering in comparison. So they're more likely to report at least one disability at every age, but then that gap widens slightly among older cohorts. And they still have nearly twice the likelihood of disability, especially relative to cisgender men at every age. Next slide, please. I also want to highlight that in the logistic regression models, which I'm not going to show you here today, but in the process of controlling for various underlying factors, socioeconomic status and health behaviors did reduce the size of the gap slightly, but it remained. So what you're seeing here is the fully adjusted model. Next slide, please. And so I want to briefly discuss why we might see such an outsized burden of disability among transgender adults. We know from other research that transgender adults have experienced socioeconomic inequality, so they were more likely to report that they were poor, not working, and not college educated. And so I find in my research that higher rates of disability persist even after controlling for these factors, which is concerning. And so that's to say that the roots of disadvantage among trans people are important. I saw them sort of impact the size of the gap, but that they're not everything. And that could also have to do with the fact that there are likely elements that are not being captured in my data. So the BRPIS does have fairly robust socioeconomic measures, but it's not able to control for things like measures of care avoidance, for instance, which disproportionately impacts trans populations especially. Next slide. But another contributing factor is likely transgender stigma. So the US Transgender Survey in 2015 found that nearly half of transgender adults reported having been denied equal treatment or service, verbally harassed, and or physically attacked in the prior year because of being transgender. So transgender stigma has been theorized as a social determinant of health because of this, which is just to say that these daily experiences of discrimination, both from other people, but also the way that they're built into institutions and policies, can create direct barriers to well-being and also create excess stress for this population, impacting their health later on. Next slide. I want to close by focusing on implications of these findings at 2 levels, the community and the policy level. So a first step at the community level might be reducing barriers to care, both financial and interpersonal. And this could mean requiring transgender inclusive training in medical schools, but also more broad efforts to improve access and reduce cost. Second, I really think that mitigating excess disability among trans people should involve responding to local needs. So this might mean asking yourself, what do my trans constituents or my transgender neighbors need? And third, we know that social support is an important component of aging well and accommodating disability. And so community organizing could really build new social networks for any isolated transgender adults that really need to fill that potential gap in their social network. And then at the policy level, one step to reduce trans stigma would be including gender identity as a protected identity class at the federal level. So we have to think about non-discrimination protection in both housing and employment and education as social determinants of health, but also think about things like religious refusal exemption clauses, which allow service providers to deny care on the basis of religious belief. And so that starts to raise questions about, in the context of these clauses, findings of higher disability among transgender people really raise concerns about, are we going to increase barriers to care for an already vulnerable population that has a disproportionate need for these services? Thank you so much.
See, do we have the slides? There we go. All right, thank you. So hello, everyone. I want to start off by thanking Health Affairs for allowing me to share this work on the links between disability, incarceration, and social exclusion. I also want to thank and acknowledge my wonderful co-authors, Stacey Bevan and Courtney Bowen. So mass incarceration, as many of us know, has transformed the United States over the past 70 years, with over 2 million people incarcerated in prisons and jails in the US. But little attention has been paid to the intersection of disability and incarceration. So our paper expands the understanding of how a variety of institutions, including prisons, contribute to the social exclusion of disabled people. Specifically, we use data from the 2016 survey of prison inmates to estimate disability prevalence and previous residence in other institutions among people incarcerated in state and federal prisons in the US, examining disparities by race, ethnicity, and gender. We included both psychiatric and non-psychiatric disabilities in our disability estimates, and in our estimates of previous institutional residents, we looked both at punitive institutions, including prisons, jails, and juvenile detention centers, as well as institutions that are traditionally considered therapeutic, including residential substance use treatment facilities, hospitals for psychiatric treatment, and other agencies or institutions, such as mental health facilities or group homes. So while therapeutic institutions may be intended to provide care and be more humane than punitive institutions, these institutions sometimes can reinforce social exclusion, structural oppression, and harm through mechanisms such as involuntary commitment. So our paper highlights how disability is central to understanding how incarceration occurs through diverse institutional settings and comes to be portrayed as normal, expected, or even beneficial. So next slide, please. So our findings reveal that disabled people were disproportionately incarcerated in state and federal prisons relative to non-disabled people. So as we've heard, there are different estimates of the disability prevalence in the US population, but around 26% of the general population in the US is disabled. But we found that disabled people made up 66% of the state and federal prison population. And among people in state and federal prisons in 2016, 40% reported a psychiatric disability and 56% reported a non-psychiatric disability. We also found that the relationship between disability and incarceration was stratified by race, ethnicity, and gender. So across all racial and ethnic groups, more women were disabled than men, though men still made up the vast majority of incarcerated people at around 93%. And further, of the total state and federal prison population, we found that approximately 42% were disabled people of color. Next slide, please. In terms of our estimates of previous residents in other institutions prior to their current incarceration, we found that disabled people were more likely than non-disabled people to report previously residing in all institution types. So while disabled people were slightly more likely than non-disabled people to have previously resided in a punitive institution, disabled incarcerated people were more than twice as likely as non-disabled incarcerated people to have previously resided in a therapeutic institution. So the relationship between disability and previous residence in another institution was also stratified by race, ethnicity, and gender. So women were more likely than men to report previous residence in a therapeutic institution, whereas men were more likely than women to report previous residence in a punitive institution. And disabled people were more likely than non-disabled people to have resided in a therapeutic institution across all race, ethnicity, and gender groups. Next slide, please. So in terms of policy implications, disabled people have been largely overlooked and neglected in policy discussions and debates about the criminal legal system. While decarceration is the ultimate goal, there are policy implications that impact disabled people before, during, and after incarceration. So prior to incarceration, policies that support the social and financial well-being of disabled people, including those that expand healthcare access, improve community care, expand the social safety net, and fund public health infrastructure, are likely to reduce imprisonment and reincarceration rates. Connecting disabled people to appropriate and accessible community resources, including employment, housing, and holistic care, could also reduce incarceration risks. So additionally, prisons need to consider the specific healthcare and access needs of disabled people during their incarceration. So prisons are one of the only institutions in the US where healthcare access is guaranteed by law. However, it's often outsourced or subcontracted to for-profit organizations, and the quality of care varies widely. So regulations are needed to improve the accountability of prisons to provide comprehensive and quality care. Additionally, prisons need to reduce the disproportionate segregation of disabled people in solitary confinement and ensure that people have adequate access to medical therapies, mobility aids, interpreters, and other required care assistance. Policymakers should also consider the specific needs of disabled people post-release. So many social and health benefits are terminated when an individual enters the carceral system. Reapplying for Medicaid is often a complicated or even impossible task post-incarceration. And as discussed, Medicaid eligibility for returning citizens varies widely by states, and reapplying for these services is seldom facilitated by the carceral institutions. So instituting automatic eligibility and renewal in Medicaid, or implementing special enrollment periods for Medicare upon release, would help to ensure that disabled people have access to care as they reintegrate into society, preventing delays or gaps in coverage post-release. So altogether, our findings underscore the urgent need to prevent and redress the disproportionate burden that disabled people bear in carceral settings, ranging from prisons and jails to a variety of other traditionally considered therapeutic, but still confining and segregating spaces in ways that collectively shape the lives and well-being of disabled people along racial and gendered lines. And ultimately, to reduce the social and legal exclusion of disabled people, scholars, policymakers, and advocates need to center disabled people in policy and political actions aimed at decarceration, paying attention to both punitive and therapeutic institutions and inequities at the intersections of disability, race, ethnicity, and gender. Otherwise, inattention to the relationship between disability and incarceration risks perpetuating the burden of imprisonment in the US and maintaining the social and economic exclusion of disabled people. Next slide, please. I guess that's all I have. So thank you again to Health Affairs and to all of you. And I will now pass it on to Dr. Alina Engelman.
I'm Dr. Alina Engelman, and I'm an associate professor of public health at California State University, East Bay, with Dana Craig at Sydney University in Alastair. I was from the University of California at Berkeley. I am excited to share findings about disability and emergency preparedness and response to climate emergencies. I'm a white woman with shorter than auburn hair, a blue shirt, a blazer, and a white background. In September of 2022, the United Nations Secretary General called on the world to stop sleepwalking through the destruction of our planet caused by climate change after the flood in Pakistan. Our paper brings together two different areas of disability studies, emergency preparedness and climate change, in an interdisciplinary way. We center the concept of disability justice as a way to help emergency managers and policymakers include people with disability in their planning and responses. We share case studies spanning the globe, including Australia, the Philippines, the Pacific Northwest, and areas of the global south, including Canada and Puerto Rico. We are three that scholars collaboratively working in the space with collective experiences all over the world, including Canada and Australia. Our strong connection to both the emergency and climate spaces and our lived experience with disability equips us to investigate international disability justice in an era of climate change. 2 key points. How are people with disabilities agents of change in these spaces? And second, how have government, civil society, and nonprofits responded to people with disabilities before, during, and after climate emergencies? In the case of the 2021 heat waves in the Pacific Northwest, people with disabilities were at a higher risk of adverse health impact, especially for those relying on life-sustaining equipment that require electricity in the event of a power outage. Yet, cooling centers are often inaccessible, and disabled people are disproportionately poor and less likely to have access to AC or to have stable homes in areas that are geographically protected from the impacts of climate change. Here you see flooded homes during the 2022 flood in northern New South Wales, Australia. Emergency information is unavailable in multiple formats. Evacuation centers remain inaccessible. There was disruption to essential services for disabled people involving health, social care, transportation, food, and homelessness if disabled people went up even more due to living in disaster-prone areas. Here we see one of the biggest refugee camps in the world in Kenya. In our paper, we show one way disabled people are agents of change. In Kenya, Disability Inclusion and Advisory Committee, led for and by emphasis operated for and by disabled people, work with disabled refugees on accessible assessment for essential services and living arrangements in these camps. Our key findings are, first, that people with disability have been and are agents of change. And second, government agencies, the nonprofit sector, and civil society all need to include and elevate the voices of disabled people. Really, both in preparing for and responding to climate emergencies, where disabled people have suffered greatly. What contributed to this were failure by emergency management and policymakers to recognize the fact that disabled people are agents of change, and to include disability operating nonprofits at the table. The case study in our paper showed this. Governments, civil society, and mainstream nonprofits in both the climate change and emergency preparedness and response sector can learn from how disabled people have led the disaster risk reduction efforts and initiatives worldwide. These efforts will enable disability justice by mitigating the impact of climate disaster on disabled people worldwide. We echo the rallying cry of the disability rights movement. Nothing about us without us. Thank you.
Let me begin by thanking my co-authors, Elizabeth Bell, Monica Schneider, and Dara Stralovich, without whom this work could not have been done, as well as thanking the American Association of People with Disabilities and the World Health Organization for funding this work. Political science has a lot of useful insights as to how our political system approaches allocating burdens and benefits, often tied up in ideas of which populations are deserving. The concept of anticipatory feedback, next slide, please, which suggests that policymakers allocate benefits and burdens in part based on public perception of specific target populations, has a lot of relevance to people with disabilities. Really, the question is, how can policymakers expect the public to respond to policies that benefit or harm people with disabilities, in part because of the public's underlying views of the disabled population? Now, existing research, next slide. Are we moving? Thank you. Existing research on disability and deservingness generally has found the public perceives people with disabilities to be a deserving population. But these studies mostly focus on cash assistance. COVID-19 has really created an opportunity for a new kind of research, in part because of high-profile controversies regarding the rationing of scarce medical resources, which really elevate the issue of scarcity of particular types of medical resources, in particular ventilators, in the public mind, and create a circumstance of realistic scarcity for the public that we can study. Next slide. We make use of a conjoint experiment design on a nationally representative sample of 2,500 people acquired via the polling firm YouGov. We present each respondent with 4 iterations of 2 randomly generated hypothetical patients. Respondents are informed that these patients have an equal likelihood of short-term survival with a ventilator and an equal likelihood of death without one. We randomly vary respondent gender, race, age, employment status prior to COVID, compliance with social distancing guidelines, and disability status. And we specifically chose to use particular disability diagnoses because these diagnoses are often tied up in social constructions that shape the public's attitudes towards different groups of people with disabilities. We hypothesized that there might be a hierarchy of disability, that respondents might respond differently to people with cognitive as compared to physical disabilities, disabilities present from childhood as compared to those in adulthood, and disabilities that impact life expectancy versus those that don't. Next slide. We find, and here you can see bars to the left side of the dotted line reflect greater deprioritization, bars to the right side reflect greater prioritization, that respondents gave lower priority to transgender patients, older adults, unemployed persons, people who didn't follow social distancing guidelines, and people with disabilities. Interestingly, respondents actually prioritized Black patients relative to white ones. Next slide. Now, we didn't find any significant interactions between patient characteristics, but when we examined interactions between respondent characteristics and patient characteristics, we were able to see how different responses to patient characteristics, in particular, people with disabilities, conceptualizing as disability bias, vary based on respondent traits. So, for example, and what's a very promising sign, we found that respondents in younger age cohorts showed much less disability bias. In fact, in Generation Z, it was statistically indistinguishable, the likelihood of selecting a person with or without a disability. Somewhat more worryingly, we found that disability bias was actually higher among college and graduate educated respondents, think is especially worrying given that we often rely on the idea of deferring to individuals with advanced education, doctors, bioethicists, many others, in order to mitigate concerns around bias. Our research suggests that those individuals are in fact less likely to select people with disabilities and may have greater disability bias. Next slide. Now, we also look to explore how differences among respondents might help us unpack our findings regarding race and transgender status. And we found that respondents' political orientation really played a big role in both of these. That our support for prioritizing Black patients came primarily from our politically liberal and moderate respondents. We actually also saw support for prioritizing Asian patients when looking at this population, but that the prejudice against transgender patients came primarily from our political conservatives and moderates. Next slide. Finally, and you can just, thank you. Finally, I want to highlight some of the policy solutions that we emphasized. We argued that Congress should consider creating a funding stream for state protection and advocacy agencies, federally funded nonprofit litigation shops that provide rights protection work for people with disabilities, specific to medical care. We also argued, next slide, for the greater inclusion of people with disabilities in triage teams and hospital ethics committees. Next bullet. And finally, we argued for regular review of disparities in health outcomes data when hospitals and other entities are engaged in rationing pursuant to crisis standards of care and other activities involving scarce resource allocation. Next slide. So I just want to close by saying our findings really support the disability community's longstanding concerns regarding bias, disability bias in healthcare resource allocation. And this highlights the need for continued work in this area. Thank you very much.
All right, wonderful. Thank you to all the presenters. Yeah, for me, this was, I'm still very much part of my medical training, and so it was just very fascinating to learn from you all. We'll take questions as they're coming in from the audience. We have a little under 10 minutes. There's a few questions that I had jotted down, and so for selfish reasons, I'll ask some of those as well. The first question is for Dr. Willie Horner Johnson. In your paper, you had mentioned a little bit about this increase in smoking during pregnancy amongst respondents who had disabilities and were pregnant, and it was a number that was pretty eye-opening for me, 46%. Can you comment a little bit more on that, and what does it say about health behavior in general amongst people with disabilities who might be pregnant, and why is it so high? Yeah.
Sure. Well, smoking is higher in the disability population in general. And we know that that's true among reproductive age women as well. And there are a number of reasons for that related to social disadvantage and clinicians being less likely to discuss health behaviors with people with disabilities than they are with people without disabilities. This is also a perfect example of why it's important to talk about reproductive plans. Because if it never occurs to a clinician to think about the fact that the person they're talking to could possibly become pregnant, they're much less likely to bring up things like smoking and the need to stop smoking before getting pregnant. So there's a real disadvantage as people with disabilities go into pregnancy. And then delayed prenatal care is also an issue because that's another missed opportunity to address these health risks early on in pregnancy.
Yeah, no, it makes a lot of sense, and big implications, clinical implications for how we sort of interact with patients. Thank you for that. The next question is going to be for Dr. Tyler James. You recommend in your paper that to meet communication standards for deaf and hard of hearing ASL users, Policymakers consider redesigning Section 1557 grievance process and also implement a more proactive approach to monitoring compliance of mental health and substance use treatment facilities. Given your findings, what should changes in a redesign and a more proactive monitoring focus on addressing?
Absolutely. Thank you for that question. So first and foremost, and as we mentioned this in the paper, there is a need to ensure that whenever we're dealing with these types of grievance and legal procedures, they need to be centered around the deaf and disabled people that are using those grievance procedures, and they're currently not. And so we recommend working with consumer advocacy organizations such as the National Association of the Deaf, which also has several barred attorneys that work within the Supreme Court to work on the redevelopment of these types of grievance procedures. Deaf and hard of hearing individuals, along with many people with disabilities and the general public, actually don't have a lot of medical or legal resources to engage in this type of grievance process. So the grievance processes that are currently available require that the deaf person either contact Office of Civil Rights within the Department of Health and Human Services, an internal grievance within the healthcare organization, which may take about 60 days. It may not lead to a resolution that the deaf person wants, or file federal lawsuit, which there's a lot of, there's a long length of time there for those types of lawsuits, and litigation is very expensive. And so we recommend that we work first with deaf consumer advocacy organizations to figure out how can these grievance processes best be designed for deaf people and for disabled people? Because maybe that's OCR having video remote interpreters or litigation attorneys that are available who can communicate in sign language directly. That's just one example.
Thank you. Yeah, no, I think design and how to make the process more accommodating, because it's already it feels like such an uphill battle. Thank you again. I think we have time for maybe one more question. I'll ask it to Lauren Bixby, and we have about 2 minutes. So sorry for not giving you much time. But in your paper, and then also in your presentation, you talk a little bit about the consequences of existing disability for people when they end up in carceral settings. Maybe if you can elaborate a little bit on that and give us examples. Again, my field is mental health, and so I'm especially interested in that. Yeah.
Sure. And are you, to clarify the question, asking about like the experience of being incarcerated as someone with an existing disability? Is that?
Yeah, exactly.
Okay.
Yeah.
Happy. Thank you for the question. I think there are a lot of just amazing studies that have really talked to people directly about their experiences of being incarcerated. And I think prisons both represent, or our findings in terms of how many people are disabled people are represented in prisons represents both the the targeting of disabled people by criminal legal system, but also the disabling natures of prisons. So prisons themselves can exacerbate existing disability, and especially the high levels of stress and social isolation, exposure to violence or infectious diseases can add to the high levels of disability that we're seeing. And there are also stories of people, say, for example, someone who's a wheelchair user and the cell is inaccessible, so they end up being placed in solitary confinement, or there's not access to an interpreter for someone who is deaf and they end up being excluded to separate spaces or not having any access to communication. And so there are a lot of different, experiences that do vary by type of disability, and then the experience of being incarcerated itself can lead to additional disability or new disability as well.
Yeah, it seems like a process that can kind of just build on itself, and it feels pretty bleak. Thank you again. Thank you to all of you for your presentations. Thank you for bearing with some technical glitches. Alan, I'll turn it over to you. I know we want to finish on time.
Thank you, Dr. Begg, for walking us through this session, and thank you to all the panelists. A tremendous amount of content that I know we could spend more time on. I hope our listeners will look at the papers, and that will be an opportunity to get a little more depth. This brings us to the end of our event. I do have a few things I want to say before we close. We really do try to finish on time here at Health Affairs. First of all, I do want to acknowledge Kyle Duarte for providing some of this accessibility services. Our interpreters were Andrea and Juniper. Our captioner was Carla. We appreciate, we are on our own learning journey, and we appreciate your participation in the event today. As I mentioned at the outset, we have some other activities associated with the issue release. A video interview with Judy Heumann will be released shortly, available on our website and our YouTube page. An in-person event at Main Street Connect in Rockville, Maryland on Thursday evening. And additional content will come out in various formats over the course of the month. I do want to acknowledge the support of our funders. Again, this is a lot of work goes into this, and we had support from the Ford Foundation, the Robert Johnson Foundation, the John and Catherine T. MacArthur Foundation for everything we've done associated with this month's issue. Our moderators to all of you, and our issue advisors of the larger team at Health Affairs making this possible. It really is a team effort. So we appreciate your interest in the topic. This event is recorded. It will be available at no charge on our website. If you enjoyed it or want to watch it again, please come back and take a look. All of the slides and the like will also be available after the fact. Thanks to the many people involved in making this a successful event, and we really do hope that the conversations that began today will continue in multiple forms. We saw a lot of really interesting policy recommendations come up this afternoon. There's clearly a tremendous amount of work to do. We know this is just a little part of it, but we're happy to be able to be a part of that conversation. And we're just grateful for the participation of so many. With that, again, thank you all for being a part of the event today, and we are adjourned.